Assalamu alaikum and very good evening everyone. Today we are going to continue our FAR 391 lectures by discussing the introductions to pharmacoeconomics. In previous lecture on the introductions to basic economics, we have discussed about scarcity and the reason for us to make a choice because of it. And there is nothing more real, more closer to us than the scarcity in healthcare. So the scarcity of resources in healthcare forces us to choose, ration and prioritize what we need to treat, what we need to do in the healthcare. So in hospital budget, for example, it's not like an infinite resources. It is just like a pie cake. So each one have their own budget allocation. For example, here you would see the cardiology, the nephrology, the rehabilitation, and also the psychiatry. So taking a bit more or increasing a budget to cardiology, it doesn't mean that we are going to add another piece of cake here. But what happened is that in order to increase the size for the piece of cake for the cardiology, we are going to take it from some other pieces here or here as well. So in reality, it means that we are going to choose. When we are investing more into a service, we are actually taking out resources from a different service in the healthcare. So for example, if you are going to take it for the cardiology, so maybe what we are doing is actually taking the resources from either the premature care or the geriatric service in order to support the increase of the hospital budget for the cardiology. So the problem of choosing is a dilemma. Some actually want to just leave it to chances, toss the coin or throw the dice, or some actually just make a very simple solution. Perhaps, for example, in this caricature here, where they are asking patients to just share the resources. But this is perhaps not very possible, especially we want privacy in healthcare. So in order to make the choice, facing the reality of the scarcity of resources, facing the reality that we actually have to make a choice, we don't want to leave that choice to luck or random decision like on a dice. We want to make sure that we have a rational criteria when we try to make the choice. So there have been many criteria being used in decision making. One is perhaps known as based on the questions of efficacy. Can it work? Does the health procedure, service or program do more good than harm to people who fully comply with the associated recommendation or treatment? So for example, if you have these two drugs here, A and B, where the old drug A can let the patient survive for 7 years, whereas the new drug B let the patient survive for 10 years. So if you're using the criteria of can it work or which one have the better efficacy, so we would definitely go with the new drug, which is 10 years, give us a longer survivor compared to the 7 years with the old drug. So, but sometimes people also are looking into another criteria, whether does the medicine work in the real practice. So efficacy relates to when the drug is working in a controlled environment. So effectiveness referred to the whether the drug is working in the real practice situations. So in this case, the same thing as well, if we have the new drug, which have a longer survival compared to the older drug, so we would, of course, would choose B based on this criteria of effectiveness. But just focusing on effectiveness or efficacy alone might mislead us in our decision making. So let me just take you to these examples. 30 years ago, where there is an evidence that suggests 6 cancers out of 10,000 would not be identified, false negative, if only 1 test was done. If 6 tests were done, the number of false negative would fall to 0.0 0.0003. Because of this evidence, the American Cancer Society endorsed a protocol of 6 sequential stool tests for cancer of the large bowel. So the economists then take this as a case study, and this was published by Newhauser and Lewinsky in 1975. They analyzed this decision by the American Cancer Society in terms of the impact to the cost of diagnosing bowel cancer with stool tests. So if we do one test, we can actually be able to detect 235,525 cases of bowel cancer at a total cost of $277 million. If we do 2 sequential tests, we'll be able to detect a total of 255,152 cases at a total cost of $385 million, which means that with 2 tests, we are actually be able to detect an extra 19,627 cases more compared to just doing 1 test at extra cost of $108 million, which means that in order to detect 1 case, we are spending about $5,492. So in order to detect, if we do 3 sequential tests, we are actually be able to detect an extra 1,625 cases more at extra cost of $80 million. And if we do the 6 sequential tests as suggested by the American Cancer Society, finally we'll be able to detect the last single case that we have been missing since the previous 5 tests at extra cost of $47 million. What can we do with $47 million? A lot, isn't it? So because of this, if you're just concentrating on the effectiveness or efficacy alone, we might forget the resources that we need to invest in order to achieve that effectiveness as found in the evidence. So because of this as well, people say that, well, maybe effectiveness and efficacy is not enough for us to arrive at our decision making. So then people are using another criteria that has been used in decision making is a criteria of price. So if you have the old drug which priced at 10 ringgit and you have a newer drug B 20 ringgit, twice more expensive compared to the old drug, so you would be choosing A because it is cheaper compared to B based on the criteria. But price alone might not be good enough criteria. So sometimes you have the old drug which is actually fraught with a lot of safety problems. There's a lot of adverse reaction which require expensive treatment compared to the newer treatment, the newer drug, which might only have very negligible or minimal adverse drug reaction and consequently would have a reduced cost of ADR treatment. So there we go. What we have is that we have a mixed evidence, mixed results of efficacy. So where you have drug B is actually better compared to drug A. And we have also evidence that the price for older drug is cheaper, but also have a more expensive ADR treatment. So what we have is, we have a big dilemma, a confusion. If you are looking at efficacy alone, you might have a different conclusion. If you are looking at the total cost, you might have another different conclusions. So what we have here is that we know by now that we might not be able to actually rely on one single criteria alone. And because of this, what we need in order to help us make an informed decision making is a tool that can actually combine both information. And this tool is what we call as economic evaluation. It is a tool that compares both costs and consequences of alternative programs or treatment. The aim is to achieve a given benefit at the lowest cost. The aim is to achieve a choice that gives us the greatest benefit for a given expenditure. So in a nutshell, economic evaluation is defined as a comparative analysis of alternative courses of actions in terms of both their costs and consequences. The basic tasks of economic evaluations are to identify, measure, value, and compare the costs and consequences of the alternative being considered. So, in order to qualify for economic evaluation, not all economic study is an economic evaluation. So, there are two questions that you need to answer in order to qualify a study as an economic evaluation. Number one, are both costs and consequences of the alternative examined? So, if the study, for example, only looking at the cost of an intervention. For example, a study is looking at the cost of treating asthma. So it only qualifies as either the cost description or cost analysis study, because it doesn't include looking at the output or the consequences of the treatment. Okay. So another questions that need to be asked in order to qualify a study as an economic evaluation is there a comparison of two or more alternatives? So if a study, even though they examine both costs and consequences, but it does not examine at least two alternatives, it does not qualify as an economic evaluation. For example, if you have a study, assessment of the costs and consequences of treating patient with insulin for diabetes. So it doesn't qualify as a full economic evaluation because it only looks into one alternative, which is insulin. So it only qualifies as a partial evaluation, efficacy or effectiveness evaluation, or perhaps cost and outcome descriptions. So because, again, it does not examine alternative. So there are only three types of full economic evaluation, three types of studies that qualify as full economic evaluation, which is cost effectiveness analysis, CEA, cost utility analysis, CUA, and cost benefit analysis, CBA. So all these three methods measure the same unit in cost, which is in the dollar sign or ringgit sign, whichever currency value that you're using. The only difference between the three of them are how they take into account the benefit unit. In cost effectiveness analysis, the benefit unit are being accounted in their natural form, in how it is being measured in the study or being collected in practice. So in cost utility analysis, this natural outcome is being converted into the utility value, which combine the information about quality of life and the survival of the patient, or in simpler form here as a QALY. In cost-benefit analysis, the benefit, which was measured in the natural unit of outcome, were converted into monetary value. And this is what cost-benefit analysis is. What we're going to do in this FAR 391 is we are going to discuss each of these tools, CEA, CUA, and CBA, in their respective lectures. So this is what I'm going to show you is just some of the examples of cost-effectiveness analysis or published cost-effectiveness analysis in the literature, so that then you can have a better idea what is actually a cost-effectiveness analysis or economic evaluation study is. So these examples is looking at the cost-effectiveness of home-based medication review in older people. So what they are comparing in this study is that whether a home-based medication review, which is a review by the pharmacist where they visited a high-risk patient at home in order to give an intervention so that then we can improve or solve their drug-related problem. the comparator would be the usual care where there is no home medication-based review. So in this study, so what they happen is that they have it as a control trial over a 6 months period for geriatric patients more than 80 years old returning home from emergency admissions to hospital with more than 2 discharge drugs. The intervention group, which is the home-based medication review group, will receive 2 home visits by a pharmacist within 2 and 8 weeks of discharge. So the pharmacist will educate patients and carer, remove expired drug, inform the doctors of drug reaction or interaction, and inform the local pharmacist if an adherence aid was needed. So another group would actually just receive would receive the usual care. So what they observe in this 6-month study is that the average cost in the group that received the home-based medication review is more expensive compared to the control, £1,695 per patient, compared to the control, which is £1,424 per patient. And this is actually expected because you have an extra resources being involved to provide that intervention. You have pharmacists who have to go and visit, so you have to pay for the transportation of the pharmacies. You have to pay for perhaps an adherence rate aid given by the pharmacist in order to solve perhaps the adherence problem by the patient. So that can add in to the increased cost for the HMR group. So what we see as well, interestingly, is that patients in the HMR also have more hospital admission compared to the control group. But they have a slightly longer survival, 0.4689 compared to 0.4618 years in compared to the control. So you have to see here that this is the survival is actually in the year unit. So a full year, because this study is only 6 months, so a full year is actually 0.5. So what happened here is that we have here patients who actually did not survive until 0.5. So on average, some of the patients die, but on average, the survival for the group in HMR is actually slightly better compared to the control. When you include the quality of life into the benefit, so what you have is a quality term which actually shows that the HMR group have a slightly better quality of life compared to the control group. So all in all, the results that we see is that HMR, the cost to gain one benefit with HMR, we have to pay an extra £54,454 more compared to just using the usual care. So it means as well that the intervention is more expensive and more effective, and the amount that we have to pay in order to get one benefit is actually more than what the society are willing to pay. We have to pay 54,454 cases more to get one additional benefit compared to just using the usual care. And this is actually, for the society of the United Kingdom, it is more than what they are willing to pay, which is maximum at £30,000. So when they plot this on a graph, on a sensitivity analysis, trying to see, based on the available evidence of the uncertainty surrounding the parameter, they found that the intervention, the home-based medication review, only have 25% probability of being cost-effective. So if you are the decision maker, and a decision can only means that it only have 25% chance of being a good investment decision, would you make that investment? So as you can see, the conclusion from the study is that they will say that this HMR policy need to be reviewed. It is not a cost-effective healthcare service because there is only a small, non-significant gain in quality of life. There is no reduction in hospital admission. In fact, what we saw, it was the opposite. And there is also a low probability of it being cost-effective. So the results of the study shows that home-based medication review is actually not cost-effective compared to usual care. So there are also other examples of study that I'm going to show here, which was being done by the group in USM. So one is that the study that we are looking at the pusat serenity option for people who are addicted to opioid in Malaysia. So you know that in Malaysia, you have an option, if you are drug addict, to either go to pusat serenity or you will be enrolled into the methadone clinic in the hospital. So what we are looking at in the study is methadone more cost-effective compared to serenity for opioid-dependent patients in Malaysia. So what we found is that, yes, methadone is more cost-effective because serenity you have to have a lot of capital investment, and there is also a lot of relapse case in patients who are receiving serenity. So there was another study that we did looking at the dispensing separation in Malaysia. So dispensing separation is a very old healthcare issues in Malaysia. So it's been there since even before the time of the first pharmacy lecturer in Malaysia. So we have been discussing that a lot, but there is always a mixed and strong reaction by either the doctor or the pharmacist, but there is no action. So because of this, what we have in USM is that, because ideally we want a case study where you can observe in real practice, but in economic evaluation, we are actually able to simulate what would happen if we have dispensing separation in practice. Will it be cost effective or not? And this technique is what we call as decision modeling. So what happened in this study is that we simulate if a prescription is dispensed by a pharmacist and a doctor, and then each of these decisions would result in either a generic drug or branded drug will be dispensed, and whether there is a medication error occurring, and whether that medication error result in adverse drug reaction that would lead to either the patients survive or die. So each of these decisions, the choice that we have, either dispensing by the pharmacist or dispensing by the doctor, would result in the same event, but perhaps with a different probability based on the evidence that we have. So what we found is that if, for hypertension case, for example, dispensing by the pharmacist would allow us to actually save 355 ringgit per prescription. And if you, for dyslipidemia, a prescription dispensed by the pharmacist, because of the benefit that we can gain from the reduction in adverse drug event, and also the gain that we can get from the productivity, we actually be able to save 437 ringgit 44 cents per prescription. So we are going to learn about all this technique, cost effectiveness analysis, cost benefit analysis, which is what we've been done in this dispensing separation cost analysis, and also the modeling in the latter part of our lecture in FAR 391. So a lot of the studies that I'm showing here, the simulation of the economic benefits of improving glycemic control in Malaysia, or perhaps looking at the cost effectiveness of single-use dialyzer compared to the reused dialyzer, were actually being done using a simulation, modeling simulation. So this is all what we are going to discuss in the rest of the lecture for FAR 391. So what happened at present, because of the high benefit expected from using economic evaluation to inform decision making, so the HTA, or what we call as health technology assessment, found that using cost effectiveness analysis study would actually help them to make a decision. So HTA is a process at the policymaker, health policymaker, where they are evaluating a new drug or a new service. So they assess all this evidence, whether the new service have merit, or was it credible enough to be allowed into the country. So what happened was, previously, the HTA only looked into the evidence of safety, efficacy, or of quality. But now, because they saw that what the cost effectiveness or economic evaluation, what sort of information that this economic evaluation can give to them and help them make decisions. So now HTA increasingly require economic evaluation evidence or efficiency evidence in order to inform their decision making. And in addition to that, they are also realizing, but not only that they are looking at the evidence of efficiency that will allow them to actually make a choice that give them a maximum benefit at the lowest cost, but they're also asking evidence of affordability. So even if the drug is safe, if it is effective, it is of good quality, it is efficient, it doesn't mean that the hospital or the country can afford it. And this is why the HTA also require the evidence of budget impact analysis, which we will also be discussing in this FAR 391. So pharmacoeconomic evidence has been increasingly used in drug regulatory across the world. So you would see that anywhere that you go, there is a high chance that if you are in the regulatory, or if you are in the practice, or even if you are in the manufacturing, you would see that the pharmacoeconomic evidence being asked not only by the drug regulatory, by the country regulatory, but also by the practice, in order for them to actually decide which practice is the best for a specific indication. So in Malaysia, we have made it more or less required to have pharmacoeconomic evidence in order to make a clinical decision making or reimbursement decision making. But we are actually limited by the lack of quality local evidence. As you can see, from 1999, well actually from the Independence Day until 2008, which is 10 years ago, there are only 12 published economic evaluation studies. Part of this is because we don't have enough pharmacoeconomic specialists in Malaysia. At present, we only have less than 5 health economists that actually can do an economic evaluation study for pharmaceutical product. So because of this, we need more and more people, not only who can do an economic study, but also can actually use it for practice. With that, I would like to say thank you, everyone. And please, if you have any questions, you can actually post the questions to the e-learning board, or just email me, or perhaps find me in my office. Thank you.